By Dr. Charity Oyedeji. Thank you. She is from Duke University, and the title of her paper is Assessing Feasibility of a Focused Geriatric Assessment in Older Adults with Sickle Cell Disease to Address Functional Risk Factors for Morbidity and Mortality.
All right, hi, my name is Charity Oyedeji, and I'm a third-year fellow at Duke University, and in this presentation, we will be reviewing the results of our pilot study of a focused geriatric assessment for older adults with sickle cell disease. This project was funded and done in collaboration with the Duke Pepper Older Americans Independence. There has been significant improvements in the life expectancy for people with sickle cell disease. This is largely due to initiatives such as newborn screening, penicillin prophylaxis. This is largely due to interventions such as newborn screening, penicillin prophylaxis, and hydroxyurea. So we are now faced with the unique challenge of figuring out the most appropriate interventions and assessment tools in order to improve quality of life for this aging population. The aim of this study was to evaluate the feasibility of a geriatric assessment for sickle cell disease. We enrolled 20 older adults, which we defined as being age 50 and older, in a single-center prospective cohort study. The exclusion criteria were individuals who were not fluent in English, wheelchair-bound, or had severe cognitive impairment. We collected demographics, medical history, utilization, and laboratory data. So the geriatric assessment is a comprehensive evaluation of an individual's capabilities in these following domains: physical function, cognition, psychological state, social support, social functioning, nutritional status, and medications. We included measures that were previously validated in the oncology geriatric assessment, and we enriched them with additional physical and cognitive measures. This presentation today will just be focusing on physical function and cognition. The assessments were performed at study entry and 12 months later, both done at steady state. So we define steady state as being at least 6 weeks out from a hospitalization, or at least 2 weeks out from an emergency room or day hospital visit. The primary endpoint were the proportion of individuals who were able to complete the geriatric assessment, and our secondary endpoints was time to completion, the acceptability of the geriatric assessment, and that which was identified based on a satisfaction survey, and the proportion who were approached who declined to enter the study. We assessed 25 for eligibility, 4 declined to participate, citing medical or social reasons for not participating. We enrolled 21, 1 was removed by the investigator due to multiple missed study visits, and 20 completed the geriatric assessment. We analyzed 20 for outcomes and adverse events. So these are the results of the demographic data of our population. The mean age of our population was 57 with a range of 50 to 71. Half of them were female. Half of them had an annual income that was below the median income for African Americans. Half of them were still working, and a third were disabled. The majority of them had more than a high school education, and there was only one who was a smoker. And these are the disease characteristics of our study population. 55% had a severe sickle cell genotype with SS or S-beta 0. 55% were on hydroxyurea, with 15% receiving chronic transfusions. A third of them were on long-acting opioids, with 85% being on short-acting opioids. And the majority of them had chronic sickle cell complications such as retinopathy, avascular necrosis, with the fourth requiring joint surgery at some point in their life. Half had acute chest syndrome in their life, and a third of them reported being hospitalized in the last year, and 75% reported having a severe pain crisis at home that they did not seek medical attention for. This is consistent with previous published data that shows that older adults and younger adults have similar opioid utilization, but the older adults have less hospitalization, and this may be due to just better self-management in the older adults. So we have here the results of our physical performance testing. And just to reiterate, the mean age of our population was 57 with a range of 50 to 71. Gait speed, which is normal walking speed, and it's a measure of mobility and health. Timed up and go is the time it takes to get out of a chair, walk around a cone, and sit back down, and that's a measure of balance. 30-second chair stand is the number of times you can get out of a chair, sit back down within 30 seconds, and that's a measure of lower body strength. And 6-minute walk is the distance traveled in 6 minutes, and it's a measure of aerobic endurance, and it's a measure that we're very familiar with in the sickle cell literature. So the actual scores for the gait speed show that our study population is significantly slower than what's expected for their age. They take longer to complete the timed up and go compared to what's expected for their age. They perform less 30-second chair stands than what's expected, and travel a significantly shorter distance than what's expected for their age. Based on normative data published by Stefan et al. And Rickley et al., these individuals with a mean age of 57 are performing at a functional age of 70s to 80s. This is 20 to 30 years older than their chronological age, and this is also consistent with prior data that shows that individuals with sickle cell disease have an early functional decline and early mortality. I have here the results of the gait speed by age. So just to bring this into the real world perspective, the speed required to cross the street is 1.2 meters per second for the general population. The majority of our participants fall below this threshold. In geriatrics, gait speed is considered one of the most powerful predictors of health. If you walk slow, your health is likely to be poor. So slow walking speed is associated with premature death, high utilization, increased risk of hospitalization, institutionalization, and even dementia. So the majority of us can cross the street without thinking twice about it, but for our patients with sickle cell disease, they're struggling to meet this threshold. This may also indicate a higher risk of complications for these patients. And we have here the results of the Montreal Cognitive Assessment, which is the measure we use to measure cognition, and the Wide Range Achievement Test, which was a reading test that every participant received. The suggested cutoff point for the Montreal Cognitive Assessment is a score of 26, so a score of less than 26 equals mild cognitive impairment. I've also included here as a cutoff point the mean MoCA score for ethnically diverse populations. We see here that several of our participants fall below this mean cutoff score for the ethnically diverse populations, and 50% of our participants met criteria for mild cognitive impairment. We also have here the results of the Wide Range Achievement Test, and we see that the stated education level is often inconsistent with the reading grade equivalent, as demonstrated by these individuals here in the blue and black, who are college educated but are reading at 2nd to 5th grade reading levels. These are things that are important to take into account when you're interpreting the results of cognitive testing. Now, when looking at the feasibility parameters, which is the meat and potatoes of what we're here to talk about, 100% of our participants were able to complete the geriatric assessment for sickle cell disease. The median duration of the assessment was 97 minutes, with a range in a quartile range of 87 to 112. 20% of the participants who were approached declined to enter the study, and on the acceptability survey, 95% reported the length as appropriate, even though it was 97 minutes. 10% reported the MoCA as the only part that was difficult to do, and one participant found that the questions on the social support scale were uncomfortable. So in conclusion, the geriatric assessment for sickle cell disease is feasible and also safe. Patients found it to be acceptable, and actually several participants found it to be enjoyable, and is able to identify modifiable deficits. So the next steps are to measure resilience using activity monitoring, compare pre- and post-hospitalization geriatric assessments, and assess variability of biomarkers of inflammation, coagulation, and joint damage over time, which these are all measures that we've been collecting throughout the prospective study. We will then validate a focused geriatric assessment in a larger study, and then develop interventions to address the deficits that we identify. So I'd like to thank all of our study participants, our research mentor, Dr. Strauss, and our collaborators in the Pepper Center, and to thank ASH, the Duke Pepper Center, and the Reach Equity Center for funding, and my mentorship committee at Duke, and I'll open the floor for questions.
Thank you, Dr. Oyedeji.
paper is now open for questions.
Thank you very much. That was great. I'm Jane Little from UNC. It looked like the men who don't have sickle cell disease walk farther than women who don't have sickle cell.
Well, they all have sickle cell disease.
No, I'm talking about you had normal, like not normal, but people
Yes, that's correct.
And so it looked like men walked farther who didn't have sickle cell disease, but the men who did have sickle cell disease walked much less. Do you understand that?
Yeah, so, and this is something we're seeing in all of our measures, that our women tend to perform better than our men. And we know that women live longer with sickle cell disease live longer than men with sickle cell disease. But this is also showing that that men are having a faster functional decline compared to women. And it's not quite clear what the milieu of the older men with sickle cell disease is compared to the women, but these are things that we're seeing, and which may mean that we really need to be more aggressive about these intervention in men, because they are going to die at an earlier age compared to the women.
Good morning. That was a really fantastic presentation. Thank you. I'm Vinay Tubman from Texas Children's Hospital, and as a pediatrician, I have to wonder if you have any thoughts about when the functional decline may begin, because there may be an opportunity to intervene earlier.
Yeah, absolutely. And so I know that there's been data on 6-minute walk in kids, and even it shows that some of the children with sickle cell disease take longer to complete 6-minute walk. So that's the only measure one of the strongest measures we've been using in the sickle cell community, and it's been showing that they have worse aerobic endurance compared to their counterparts. So we know that this functional decline starts early, and I agree that we will need to be doing some interventions to address this earlier on. And I think some people have had some papers or talks about exercise, like starting exercise to address some of the functional decline earlier on in life. And so I agree that, with this, I don't know if you're able to see my slide, I guess the slides are gone, but our patients, they're functioning like 80-year-olds even though they're 50, which means that we've kind of missed the boat on a lot of people if they're already, the further along geriatrics, what do you call them, super geriatric patients. So this may mean that we need to start earlier. And one of the things that we've been doing is actually recruiting younger adults, age 18 to 49, as a comparison group, just to see how this test performs. And then we'll follow them longitudinally to see how this functional decline happens over time.
It was quite a fantastic talk, thank you. Marianne de Montalembert, Paris. Could you compare some data with the results of MRI findings? Did you correlate your findings with the results of MRI findings, especially for the presence or not of silent infarcts?
No, we have not, but that's one of the things that we've been discussing of maybe doing like functional MRI or just MRI, but we have not compared the cognitive testing, but it's been done previously. I think Dr. Baczynski published a paper on looking at silent strokes and IQ testing, so it's something that would be very interesting.
And secondly, would you have a threshold telling, for instance, that after the age of, 35, 40, 45, you have to propose such systematic examination? You have not given a threshold of age. You're telling us that we have to start at 40, 45. You count on that?
So no, we haven't developed a cutoff for age. So this was just feasibility, and we chose an arbitrary cutoff point of 50. But eventually, we'll have to decide on where appropriate cutoff will be. But we haven't decided. But I'm thinking, based on these results, that starting earlier, so at a functional equivalent of at least 60, would be reasonable, which is what they're doing in geriatrics. So starting at the true geriatric age of 65. So I imagine of a more of a functional equivalent will be like 30 in our population.
Yes, just a comment, when looking at your data about 6-minute walk distance, these are the results in your elderly people. We found in children, we performed studies in children, and these 6-minute walk distance was exactly the one we found in children and adolescents. So it occurs, the abnormalities occur very early.
Yes.
Susie Curtis, Yale. That was a great presentation. Thank you very much. I'm just curious, especially moving forward, and now that you're going to pull in that younger population too, are you going to do something to look at the fact that this geriatric population is by their nature a survivor population? You know, they've already made it well past the median age. So how to sort of distinguish what's different about this population where your younger population might be more heterogeneous?
Yeah, so which is why I mentioned that following these younger population for a longer period of time will give us some insight of when these functional declines are happening. And so I think we'll be able to better see the differences and when these falling off the cliff or starts to happen.
Thank you.
I have a question, I guess, more of a comment. So I think the cancer literature, cancer survivorship, they look at frailty, right, as a marker of one of the things that they monitor in pediatric cancer survivors. So do you think there are parallels with the early aging that you're observing in your adults with this frailty that is seen in cancer survivors, and can we learn something from the way the assessments are being done? It's just, and it's curious because they also have early aging, right, and you're still observing the same thing.
Yeah, which is why this geriatric assessment was so important in the oncology population, and which is, when we see a patient with sickle cell disease get out of the hospital, they are frail. Like, they meet the phenotype for frailty. And so, which is why, and which I mentioned in our slide, that we're also doing this assessment post-hospitalization, because that's a really big time where these people are meeting criteria for frailty. So they're the phenotype of what we see in the geriatric and even the cancer population, which is why this assessment is so important, and to not only do it, but then address the interventions in order to fix these issues as much as we can.
Yeah, that's fascinating.